Hello, friends. We're talking on this topic, macrophage activation syndrome. So this talk, I gave it in W4C that was conducted in Bhubaneswar on 21st September 2024. So I wish to acknowledge my colleague, Dr. Pradeep Surli, for helping me developing this content. So I'm sure most listeners would know that in ICU we deal with HLH, which is hemophagocytic lymphohistiocytosis. So macrophage activation syndrome is sort of a synonym of HLH. So there is no huge difference. There are subtle differences between macrophage activation syndrome and HLH. And it's a distinct sort of cohort of patients where we call it as macrophage activation syndrome. And I'll elucidate that subtle differences. But for all practical reasons, they pretty much are the same, HLH and macrophage activation. So we'll talk about HLH, what really happens. So in HLH, there is sort of activation of all different sort of inflammatory cells within the body. And this activation of all the cells could be triggered by either an infection, by a cancer, or by autoimmune conditions. So that's usually a common trigger. And because there is hyper, as the name says, hemophagocytic lymphohistiocytosis is a hyperinflammatory reaction, and this has a direct bearing on increase in the mortality when such a situation arises in an individual. So the basic pathognomonic sort of a reason for having this hyperactivation of all the cells is inappropriate survival of these histiocytes. So this is the morphology of histiocytes and cytotoxic T cells or T lymphocytes. So these are the two cells. There is an inappropriate survival, which leads to sort of a cytokine storm that happens. And along with cytokine storm, there is hemophagocytosis that happens. So there is a engulfing of its own cells by the histiocytes, by the activated histiocytes or hemophagocytes or the foamy histiocytes. And this leads to multi-organ dysfunction and eventually increase in the morbidity and mortality. So in HLH, when we talk about HLH, there can be familial because of the genetic aberration that happens and secondary HLH. So, but what we generally tend to see in ICU is the secondary HLH we tend to see in adults. And the triggers, as I said, very often can be due to underlying cancer or it can be due to underlying infections. And these infections can be bacterial, viral, rickettsial, but very often it will be due to viral and autoimmune. So what is macrophage activation syndrome? So macrophage activation syndrome is a nomenclature or a term given to HLH that is triggered by autoimmune condition. That is when we call macrophage activation syndrome. So as you see, the difference is not much. It is just about the nomenclaturing and there are subtle differences. So macrophage activation syndrome is a term that's given for HLH where the underlying etiology or the trigger is the autoimmune condition. So that's what it is. And it was first described by Stephen et al. In 1987. And this was endorsed by Histiocyte Society classification. And macrophage activation. So this is the morphology of macrophage, which is activated, releasing a lot of cytokines. So tends to occur mainly in pediatric or adolescent rheumatology. There are specific rheumatological conditions which act as a trigger for macrophage activation syndrome. The common ones is systemic juvenile idiopathic arthritis, shortly called as SJIA, or SLE, which we do come across in ICU, and Kawasaki disease in children. In adults, it carries bad outcome, and juvenile dermatomyositis. So these are the underlying rheumatological conditions which act as a major trigger for macrophage activation syndrome. So the signs and symptoms, like in HLH, I'm sure many of you would have seen HLH in ICU after they've had viral infections. The infection has come and gone. They tend to have high-grade fever. So the nature of the fever is intermittent and non-remitting. It doesn't remit. There'll be an ongoing fever. And the classic thing is they'll have lymphadenopathy. So lymph nodes will be enlarged. Then there is coagulopathy. So they'll have pancytopenias, they'll have coagulopathy and very high ferritin levels. So the ferritin levels will be very high. And the key pathognomonic thing is they'll have organomegaly. So there can be hepatomegaly and there will be splenomegaly. And cytopenias will be there. It can be bicytopenia or pancytopenia. So your cell counts, total cell counts will be low, platelets will be low, coagulopathy will be there. Because of coagulopathy, low platelets, and pancytopenias, they can have DIC, they can have GI bleeds, so on and so forth. So if you look at this symptomology, very hard to delineate between a SARS or sepsis. So the key hallmark is that you have to have high index of suspicion and do look for at least the ferritin aspect or the pancytopenias that are occurring and non-remitting fever and lymphadenopathies. So these are the sort of a clues that will help you to recognize early on. And early recognition is important because you don't recognize this, these patients will die. You need to recognize it, prognosticate, and start treating with steroids or any other drugs. And that has shown to improve morbidity and mortality. And HLH or macrophage act, I may be using these terminologies interchangeably because both are pretty much the same. So they tend to have neurological symptoms where prognosis can be even bad. And neurologically, they can have confusion, coma, seizures, or chronic headaches. And this occurs in 35% of the patients with HLH bar macrophage activation syndrome. And eventually, they will die of multi-organ dysfunction. So this is the symptomology. So symptoms or signs can be pretty much similar to sepsis, but look for lymphadenopathy, look for organomegaly and ferritin. Because for all the viral infections that come to our ICU with organ dysfunction or rickettsial infection, do ferritin because ferritin is a good marker to tell you that whether one has to suspect HLH or macrophage activation syndrome. So when you look at epidemiology, the exact incidence of macrophage activation syndrome in rheumatology is unknown. So there's one study by Ravelli et al., which has put the prevalence of systemic infantile juvenile arthritis or systemic idiopathic juvenile arthritis as 10%. Mortality is 8% to 23%. But the subclinical cases, they put it at as 40%. So many of them can be subclinical, but the over clinical manifestation is at 10%. And subclinical the diagnosis has to be established by doing bone marrow testing. So one has to do bone marrow to establish the diagnosis. SLE, the prevalence of MAS or HLH is 0.9 to 4.6%. And as you see, there is a good correlation with increase in mortality 5 to 35%. And SLE also, the occurrence of HLH bar MAS increases when there is a concomitant liver dysfunction. It increases to 9.4%. Kawasaki disease, the prevalence is put at 1.1%. In adults, it carries a very high mortality up to 50% or more than 50%. So this is the sort of a sketchy epidemiological data we have. We don't have too much of a robust data because these are all rare conditions. So when we talk about pathogenesis, as I mentioned, the two main cells that are involved is the cytotoxic T cells and natural killer cells. And the cytolytic function of these cells, there is a failure. There's a failure of this. As I said, there is always a trigger for HLH or MAS. So it could be underlying malignancy or it could be underlying pathogen or autoimmune. So in all these conditions, they all present with an antigen. So when there is an antigen in the body, this antigen needs to be clear. So there is inability of clearance of this antigen. So there is no clearance of this antigen. So there is perpetually this antigen is present within the body, which activates all the inflammatory cells. So there is inappropriate immune stimulation because of a constant presence of this antigen. This leads to increase in the interleukin 1 and that leads to cytokine storm. And this cytokine storm leads to hyperferritinemia. There is increased ferritin and that leads to expression of the NF-κB. And that leads to a lot of signaling, which leads to pro-inflammatory sort of a storm or pro-inflammatory cell proliferation. So this is in brief about the pathognomonic. So basic quintessence is that antigen is not cleared. Perpetual presence of antigen leads to inappropriate activation of the immune system, more production of interleukins, cytokine storm, ferritin, expression of NF-κB expression, which leads to signaling pathways, which leads to a lot of pro-inflammatory cells that get proliferated. So that is in essence. And there are certain unique mechanisms like Epstein-Barr virus leads to HLH bar macrophage activating. So they specifically act by inhibiting certain proteins, like it inhibits the SH2 domain of the protein 1A. So each virus have certain different unique mechanisms. For Epstein-Barr, they have identified SH2 domain of the protein 1A component, which leads to activation of MAS. So again, to show a pictorial representation of pathogenesis, so these are the malignant cells with the presenting antigen presenting cells. And when there is an antigen presenting cells, there has to be activation of natural killer cells and the cytotoxic T lymphocytes, which have to remove these antigen presenting cells. And there are T regulatory cells, and there is sort of a non-activation of these T regulator cells, and this leads to proliferation of all these cytotoxic T cells, which leads to production of all these interferon gamma, and this leads to production of foamy histiocytes. So these are the foamy histiocytes, and that leads to cytokine storm and macrophage activation that tends to happen. Cytokine storm and macrophage activation leads to production of all these different cytokines or interleukins, which causes damage and multi-organ dysfunction. So this is again pictorial representation of the pathogenic mechanisms that underlies the onset of MAS. So now the question is, we have been using HLH and MAS interchangeably. So are there any key differences? So as I said, for all practical reasons, they're pretty much the same. There are very subtle differences. Like if you see high temperature, it's present in HLH, but not necessarily in macrophage activation syndrome. Ferritin is much, much higher in macrophage activation syndrome as opposed to HLH. And organomegaly is present more in HLH, but not necessarily in MAS. And pancytopenias are present in both. Hypertriglyceridemias are present in both. Hypofibrinogenemia. Why hypofibrinogen? Because there is coagulopathy and there is fibrinogen that gets depleted. So hypofibrinogen is present in both. And increased ALT LDH is typically seen in macrophage activation syndrome. And phagocytosis is more distinctly characteristic of HLH and not macrophage activation. And natural killer cells are present more in HLH sort of a situation. So these are subtle differences, but for a clinician, for intensivist, pretty much you can concur they're the same. One thing you can sort of keep in back of mind is the ferritin levels are strikingly much higher in MAS as opposed to HLH is what you can just remember that if you can. Otherwise, other things possibly doesn't matter. So now the key thing is one needs to have a high index of suspicion to make a diagnosis of HLH bar MAS. So what is a diagnostic workup? In ICU, if you have an unexplained fever after them having recovered from the initial viral or bacterial infection or initial insult, and they present as sepsis and multi-organ dysfunction, and you don't know the reason, all the cultures are coming negative, then one has to look for 3Fs. What is 3Fs? Fever, high temperature, high ferritin, and falling counts, which is pancytopenias. If you have components, 3 components, ongoing fever and pancytopenias, falling counts, and high iron, then you have to think of, is there a possible HLH diagnosis? Once you have entertained possible HLH, you have to take your phone and look into the MD Calc for H score. So you have to calculate H score. So I don't expect any of our listeners to remember the exact scoring of a score. You have ready apps. So look for MD Calcs. It comes like this. Open up your MD Calc, look for HLH workup, and you will get all this score. As you see, there is an underlying immunosuppression, temperature, organomegaly, ferritin levels, triglycerides, AST. And so you just keep adding whatever your patient has, it will give you the score. The number you need to remember is 169. Whether your H score is more than 169 or less than 169. If it is not more than 169, less than 169, you have to ask yourself whether your index of suspicion is still there for HLH. Then keep repeating the H score daily. That's all. Use your app, MD Calcs, and keep doing this score every day if you're still suspecting there is HLH. If H score is more than 169, then you have to start ordering other investigations for HLH. Then there is first line investigations, there is second line investigations, there is specialist investigations like bone marrow, and establish the diagnosis. After you establish diagnosis, you start with treatment, first line treatment, second line treatment, third line, and so on and so forth. So what are the investigations? The first line investigations is all the routine investigations, what you generally do in ICU, CBC, KFT, peripheral smear, coagulation profile, LDH, triglycerides. These are all the run-of-the-mill investigations which you would be doing. Look whether triglycerides are high, LDH is high, ferritin is very high, fibrinogen is low. And then you have to think of doing imaging if they have neurological manifestations. MRI is preferable. You can do CT if MRI isn't available. And you have to send cultures to make sure there is no underlying infections. Then one has to think of bone marrow tends to come as a second line investigations to confirm the diagnosis. So if all these are not really showing a good direction, then there is third line of investigations, which I put it as second line, where you do specialized sets. You have to do lymphocyte subsets. You have to look at all the subsets and the ratio, where you may have to get hematologists involved here. Then you have to do flow cytometries. So flow cytometry, just for our intensive care trainees, you put all the cells and there is a fluorescence which indicates different cells, how their presence is within the components, and it shows something like this with the fluorescence flow cytometry to look mainly for natural killer cells. And then you have to look at measured IgA levels, IgG and IgM levels. And these are all advanced tests. Look for soluble IL-2 gamma and CD163. So these are all the advanced tests in academic centers one could embark on doing to see what sort of a HLH bar MAS that may be present. But pretty much in ICU, for all practical reasons, we can limit to all these investigations. It will yield diagnosis. Bone marrow is definitely confirmatory. So all this is for advanced academic centers to look. And flow cytometry is something oncologists keep doing. So this is something that you can keep in mind. So once you have established diagnosis, then you have first line and second line of treatment. So the first line treatment, corticosteroid is the mainstay. So the dosage that is suggested is methylprednisolone 1 gram once a day or dexamethasone 10 mg per meter squared once a day. You have to give it for 3 to 5 days and then taper it to 1 milligram per kg of prednisolone. This is, and most of them tend to respond to this corticosteroids. And in our practice, we have been using dexamethasone as a treatment, and many of them do respond to this. And there are alternative therapies like intravenous immunoglobulin, etoposide, cyclophosphamide, plasma exchange, and all these are used as a desperate measure when patients do not respond to your first line therapy, which is steroids. So anakinra, you must have been hearing, they use it more in pediatric cases. So if there is HLH, which is very severe, not responsive to steroid, then anakinra is an IL-1. See, this is the interleukin 1 receptor, and this is the anakinra. So it prevents the action of this IL-1 beta on these receptors. It blocks these receptors. So IL-1 receptor blocker is the anakinra, which they have used for HLH bar mass. And this is for steroid refractory HLH, and the dose is 1 to 2 milligram per kg per day, and this could be increased up to 8 milligram per kg per day. So this is the dose of IL-1 receptor antagonist. So the other agents that are used is etoposide, which is considered as a second line. But the problem with etoposide is it can cause severe bone marrow suppression, it can cause liver toxicity and nephrotoxicity. So these are some of the side effects of this etoposide. And anti-thymocyte globulin, I'm sure during COVID, some of the intensivists had been using this. So these are readily available in the market. Anti-thymocyte globulin is also considered in refractory macrophage activation syndrome. So the other agents that are used as a desperate measure when they don't respond to steroids, when they don't respond to anakinra, is IVIG and cyclophosphamide on plasma exchange. But there are no big studies to say whether they have shown magical results. The outcomes have always been inconsistent when you move to second or third line sort of these drugs. So the other newer agents, so these are all about the pharmacological agents. So pharmacological agents are steroids, then you have etoposide, then you have anakinra, anti-thymocyte globulin, IVIG. Then there is new biologicals that has come, which are immunoglobulins. The newer biologicals is canakinumab. This is human anti-interleukin 1 beta monoclonal antibody, and the dosage is, as you see, 150 mg. So canakinumab has been used in some of the patients who are refractory, and they've used tocilizumab, which is IL-6 receptor. I'm sure most of the listeners are very familiar with the use of tocilizumab. So IL-6 receptor blockade also has been used as a desperate measure for treating HLH, and it has shown to have some benefit in systemic juvenile idiopathic arthritis, and it has shown to mask features of mass. In 25% of the patients do become afebrile, and use of tocilizumab has shown reduction of ferritin levels. So these are all has come in case series and case reports, but I think our protective drug of choice, which is easily available, is steroids, which we tend to use. Anakinra is also easily available. That also could be kept in back of mind. And of course, you have plasma exchange immunoglobulins, which are readily available, which could be used as a desperate measure. So the summary is HLH bar MAS are pretty similar. We call it as MIC when the trigger is an underlying autoimmune condition, and it's a life-threatening condition. It can lead to multi-organ dysfunction. So one needs to have a high index of suspicion. The main thing is there is unchecked perpetuating proliferation of inflammatory cells, leading to foamy histiocytes, leading to macrophage activation and cytokine storm, leading to release of all these interleukins. Pathogenesis, there is no antigen clearance that leads to inappropriate activation of the immune system stimulation, leading to cytokine storm. And diagnostic workup, I don't expect any of you to memorize. keep the three F's in mind, whether patient has falling counts, whether the patient has fever, and whether the patient has high ferritin. If these three are present, go to MD Cals and do the H score and remember 169. If it is more than 169, very likely they have HLH, and think of bone marrow if you want to confirm that. If it is less than 169, then pretty much you can rule out, or you have to repeat the score if it is going up, if patient condition is not improving. So stick to MD Cals to do workup. Look for organomegaly, look for lymphadenopathy, so on and so forth, and coagulopathy as your adjuncts to help you diagnose. Management, simplistically, methylprednisolone 1 gram once a day for 3 to 5 days, and wean it to 1 milligram per kg per day of prednisolone, or dexamethasone is commonly we use. So that remains the mainstay. The other agents is anakinra you can think of, on plasma exchange, etoposide, and even in severe neurological manifestations, intrathecal administration of some of these agents have also been looked at. Intrathecal administration of cyclophosphamide, so on and so forth, has been reported in some of the case reports. So we have published two good case series. So this was the case series of HLH. We published of 6 case series in 2013. And this was the slide from our own patient where you see histiocytes, which has engulfed some of the lymphocytes. And this is a recent sort of a case report that we published of HLH manifesting in rickettsial fever. So we have also done some work, and we do see this very often. So please have an index of suspicion and think about establishing diagnosis and treat it early on rather than delay. So request you all to attend to our signature event, Global Intensive Care Symposium, happening from 18th to 20th October in Namma, Bengaluru. And request you all to submit your valuable work to Journal of Acute Care. Visit my website or scan the QR code to get to these lectures. So thank you, Manoj.